Good morning. Today's talk is on surgical procedures and anesthetic considerations in the neonate. A newborn requires constant vigilance, rapid recognition of events intraoperatively, and swift intervention during anesthesia. The anesthetic considerations in neonatal surgeries are based on physiologic immaturity of various body systems, the poor intolerance or poor tolerance of the anesthetic drugs, associated congenital disorders, and considerations regarding the use of high FiO2. The main goal is for titration of anesthetics to desired effects. Neonatal surgeries can be divided into when these procedures are commonly done, like the first week of life or the first month of life. The most frequently performed surgical procedures during the first week of life include the anterior abdominal wall defects like omphalocele and gastroschisis, congenital diaphragmatic hernias, TE fistulas, tracheoesophageal fistulas, intestinal obstruction or atresias, meningomyelocele, and airway disasters. Some of these are obvious at birth, like the congenital diaphragmatic hernia, abdominal wall defects like omphalocele and gastroschisis, the meningomyelocele, while it may take a couple hours or so to diagnose TE fistulas, and some conditions like intestinal obstruction may take a while to manifest. Most of these children are in the neonatal ICU, with the exception of maybe the occasional rare airway disasters that come to the operating room straight from the labor and delivery suite. The neonatologist is a good source of information for your anesthesia pre-op. Please talk to them. The factors that contribute to increased mortality and morbidity when children undergo neonatal surgeries include prematurity, low birth weight, and associated congenital anomalies. The presence of a single congenital anomaly increases the chance of multiple congenital anomalies by about 30 to 40%. The most serious associated congenital anomaly is that of the cardiovascular system. The presence of associated cardiac anomalies, say in a patient with TE fistula, would increase his or her mortality and morbidity significantly. Then, from that, surgical correction for TE fistula with no congenital anomaly, no other congenital anomaly. Moving on to congenital diaphragmatic hernia. This clinical presentation was first described in 1804, but the operative correction was not considered possible until 1940, almost 150 years later. Congenital diaphragmatic hernia is herniation of the abdominal viscera to a defect in the diaphragm, most commonly the left foramen of Bokdalak. The incidence is around 1 to 2,000 or 1 to 5,000 births. Mortality is high. 50% of these children with congenital diaphragmatic hernia die intrauterine or immediately after birth. During fetal development, the gut can herniate into the thorax to one of these three possible diaphragmatic defects. They are the right and the left posterolateral foramen of Bokdalak and the anterior foramen of Morgagni. The left-sided herniation is the predominant defect seen in about 75% of patients with congenital diaphragmatic hernia. The etiology is really unknown. There could be a familial factor, and certain drugs like thalidomide and quinine seem to be associated with it. The associated anomalies include those stillborn infants who have about 95% of associated congenital anomalies. Live-born infants have about a 20% incidence of associated anomalies, and they're usually cardiac and most commonly primary pulmonary hypertension. Pulmonary hypoplasia occurs secondary to the herniated abdominal viscera that act as a space-occupying lesion in the thorax and prevent normal lung development. Hence, the lungs have reduced bronchial size, less bronchial branching, and decreased alveolar surface area. The compression and hypoplasia of the contralateral lung can also occur due to mediastinal shift caused by this herniated abdominal viscera. The severity of congenital diaphragmatic hernia is related to how early in fetal life the herniation and compression occurred. The classical triad of presentation in a child with congenital diaphragmatic hernia includes cyanosis, dyspnea, and aberrant dextrocardia. On physical examination, these children have a scaphoid abdomen, a bulging chest, they have decreased breath sounds, and you could possibly hear bowel sounds in the chest. A chest X-ray would show a bowel gas pattern in the chest along with a mediastinal shift. Poor prognosis is seen in infants who have polyhydramnios in utero. If they weigh less than 1 kilo, if their AA gradient, oxygen gradient is over 500, if they require intubation at birth, and if they have coexisting primary pulmonary hypertension. The perioperative care of children with congenital diaphragmatic hernia includes decompression of the stomach, avoid positive pressure ventilation as this may distend the stomach and bowel which is present in the chest. The positive pressure ventilation is via bag and mask, but if you intubate to improve oxygenation and if the patient needs to be intubated, positive pressure ventilation will not cause distension of the stomach and bowel. Make sure the patient has an arterial line and has adequate venous access. Make sure that you maintain a peak inspiratory pressures of less than 30 centimeters of water. If the patient is acidotic, treat acidosis. Support peripheral perfusion with use of inotropes if necessary. Increase pulmonary perfusion and decrease pulmonary vascular resistance and prevent right to left shunting. The methods used to reduce pulmonary vascular resistance and also reducing right to left shunt include hyperventilation. If a patient has a patent ductus arteriosus, ligation would be helpful. The use of nitric oxide or tolazoline, prostaglandin E1, and prostacyclin medications help decrease pulmonary vascular resistance. And last but not the least, ECMO. The surgical repair is usually through a subtotal transabdominal approach. The bowel is reduced from the chest and the diaphragm is repaired primarily or by use of a Gore-Tex patch if the defect is big. Intraoperative complications include hypoxia and hypercarbia, and they're usually caused secondary to distension of the bowel and the stomach, making it hard for us to oxygenate and ventilate these children, and the presence of primary pulmonary hypertension or plain pulmonary hypertension. Hypotension could be caused by compression of major blood vessels. Barotrauma-induced pneumothorax resulting in sudden hypotension and arrest usually occurs on the contralateral side. Remember, during your case, if you encounter a sudden fall in lung compliance, drop in blood pressure, or a drop in oxygen saturation may signal a contralateral, usually the right side, pneumothorax. Secondary to barotrauma, and this child would require placement of a chest tube to correct the problem. The pneumothorax needs to be recognized as soon as possible or the patient will crash on you in seconds. Postoperative management includes continuation of positive pressure ventilation. FiO2 is adjusted to maintain a PaO2 around 150 millimeters mercury. And some talk about the honeymoon phenomena, and this is characterized by an early smooth course followed by a sudden development of pulmonary vasoconstriction and potentially lethal persistent pulmonary hypertension post-surgery. Moving on to the next topic, it is omphalocele and gastroschisis, the main anterior abdominal wall defects. They both require surgical correction during the neonatal period, and the perioperative anesthetic and surgical management of these two conditions are pretty similar. And omphalocele incidence is around 1 in 6,000, though nowadays the incidence is much lower. 30% of children with omphalocele are preterm and 35% have intrauterine growth retardation. Omphalocele is caused secondary to failure of gut migration from the yolk sac into the abdomen. Whereas in gastroschisis, even though I've stated the incidence as 1 in 15,000, it is way lower nowadays and almost equaling omphalocele or maybe even more. 60% of these children with gastroschisis are preterm and also have intrauterine growth retardation. It occurs secondary to occlusion of the omphalomesenteric artery. In omphalocele, the herniation occurs through base of the umbilical cord, and the defect is about 2 to 10 centimeters. It's covered by a membranous sac, and the risk of sepsis is low just because it's covered by the membranous sac. In gastroschisis, the defect is usually lateral, usually to the right of the umbilicus and about 2 to 5 centimeters. It's not covered with a sac. The bowel is exposed and the risk of sepsis because of this is extremely high. Omphaloceles are usually associated with other anomalies. 20% of them are cardiac. They could also have cleft lip and cleft palate. They could be associated with trisomy 13 and trisomy 18, and also with Beckwith-Wiedemann syndrome. Associated anomalies are rare in children with gastroschisis. In omphalocele, the bowel structure and function is normal, but could be associated with malrotations. In gastroschisis, the bowel wall is thickened just because of the lack of a sac covering the bowel in utero. There is a delay in return of normal function of the gut, and there's a high incidence of adhesions, stenosis, ischemia, perforation, malrotation, and volvulus postoperatively. The outcome in patients with omphalocele depends on the size and associated anomalies. Children with omphalocele usually have good outcome if they do not have associated anomalies. Children with gastroschisis, the outcome depends on the state of the bowel and how early the bowel was closed. They have a higher incidence of sepsis, hence if the patient has sepsis, the prognosis is poor. With better neonatal care and treatment and surgical management, the prognosis with children who have gastroschisis is getting better. The preoperative considerations in these children include urgent closure of gastroschisis and ruptured omphalocele for obvious reasons. An intact omphalocele closure can be delayed to rule out associated cardiac and chromosomal anomalies. The herniated sac should be well protected. Heat and fluid loss should be minimized by covering with sterile occlusive dressing or a cling film. Gastric suctioning to prevent gastric bowel distension, and antibiotics should be administered. Make sure the child has adequate venous access and has had adequate fluid resuscitation. Dexterous administration should be started per gestational age and weight of the child. Electrolytes should be corrected. Make every attempt to minimize fluid and heat loss. Fluid losses and gastroschisis may require more than 100 ml per kilo of additional crystallite administration perioperatively. The surgical considerations include whether a primary closure should be done or should a staged procedure using silastic pouch to be done. Always watch for increases in central venous pressure and peak inspiratory pressures when primary closure is attempted. Omphalocele, usually less than 5 centimeters, can be closed primarily, but if they're over 8 centimeters, then should be done by a staged procedure. This is a child that had a silo pouch placed because primary closure was not possible. The second picture shows bowel reduction and then patient ready for secondary closure following the reduction of the bowel. Some effects of primary closure of omphalocele and gastroschisis include difficulty in ventilation, secondary to cephalid displacement and splinting of the diaphragm. There could be aortocaval compression and venous stasis, leading to profound hypotension. And if blood pressure and saturations are read from both the upper and lower extremities, you would probably see a significant difference in these readings, the upper extremity being close to normal and a definite reduction in the lower extremities. There could also be decreased perfusion of intra-abdominal organs like the liver and the kidney. Physiological variables used to predict the failure of primary closure include an increase in peak inspiratory pressures over 30 centimeters of water if intragastric pressures are measured and if they're over 20 millimeters mercury, a raise in central venous pressure by over 4 millimeters mercury and bladder pressures being over 5 millimeters mercury. When taking care of these children, always optimize cardiopulmonary status preoperatively. Evacuate the contents of the stomach. A general endotracheal anesthesia with rapid sequence intubation is required. Avoid nitrous oxide to prevent bowel distension. Continue fluid resuscitation intraoperatively. Full muscle paralysis, especially for large defects and facilitating closure, is necessary. Make sure the body temperature is well maintained. Postoperative considerations include ventilatory support. Large defects may require muscle paralysis for 24 to 48 hours post-op. These children could have prolonged ileus and hence would require total parenteral nutrition. The postoperative complications include necrotizing enterocolitis, renal insufficiency, abdominal wall breakdown, sepsis, GE reflux and aspiration, pneumonias from aspiration, adhesive obstructions, and complications secondary to associated disease states, especially in children with omphalocele. Moving on to the next topic, tracheoesophageal fistula. The embryology includes both esophagus and trachea originate from median ventral diverticulum of the primitive foregut. TE fistula occurs due to failure of these two structures to separate during division of the endoderm. The incidence is around 1 in 4,000. 20 to 25% have cardiac defects, and 20 to 30% of these children are preterm and weigh less than 2 kilos. Survival is excellent in children when they're otherwise healthy term infants. In high-risk patients, example, those children who weigh less than 1.8 kilos, have a history of pneumonia and other associated anomalies, the mortality is around 20%. These are the different types of TE fistula. The commonest is the C type, where the proximal esophagus ends in a blind pouch and the distal esophagus is connected to the posterior part of the trachea just above the carina. The presentations: in utero, usually associated with polyhydramnios, and postnatally, when you see these children, they could have excessive frothy saliva, they could have respiratory distress at birth, they have coughing and cyanosis at first feed, and when you try to pass an orogastric tube, you're not able to do so. A chest X-ray in these children would reveal, actually depends on the type of TE fistula. Here in the first picture, the red arrow points to the end of the OG tube that cannot be passed any further, secondary to the proximal esophagus ending in a blind pouch. Also note the lack of gas in the abdomen, indicating that a fistulous tract does not connect to the distal esophagus. The second picture shows its post-contrast, the blind dilated upper esophageal pouch. Also note the gas pattern in the abdomen, which indicates that this child has a fistulous tract connecting the trachea to the distal esophagus. Children with TE fistula could have multiple associations. Of the common association is the Vactral association. In the Vactral association, V is for vertebral anomalies, and that could present either as absent or fused hemivertebrae or absent or extra ribs. A is for anal and GI tract anomalies, could also include sacral anomalies, anorectal anomalies, duodenal atresias, Meckel's diverticulum, pyloric stenosis, and malrotation. The renal anomalies are renal agenesis, lobulation, hydronephrosis, and hypospadiasis. If a child has renal agenesis, that child is incompatible with life. The limb anomalies include radial dysplasias, thumb defects, and defective limbs. TE fistulas can also be associated with charge association, where C stands for coloboma, H for heart defects, A for atresias, R for retardation, mental or physical, G is for genital abnormalities, and E is for external ear abnormalities. The preoperative care in a child with TE fistula includes avoidance of feeding, place the child in an upright position to prevent GE reflux, continue intermittent suctioning of the upper blind esophageal pouch, initiate antibiotic therapy and H2 antagonists. Preoperative ventilatory support could be necessary due to pulmonary immaturity, or if the child has aspiration pneumonia or infective pneumonia. Modify ventilation to decrease or prevent gastric distension, diaphragmatic splinting, and gastric rupture. If positive pressure ventilation causes gastric distension, consider gastrostomy. The surgical management includes the primary repair when possible. It's usually through a right thoracotomy where a posterolateral extrapleural approach is made. If it is a one-stage surgery, then the fistula is ligated and the two ends of the esophagus are anastomosed. A two-stage surgery is if the proximal and the distal ends of the esophagus cannot be approximated, then the proximal esophagus is exteriorized, a G tube is placed, and approximation using bowel segment or gastric tube grafts is done when the child is about a year of age or over 9 kilos. In unstable or high-risk infants, a gastrostomy can be done under local anesthesia to decompress the stomach and prevent reflux and facilitate ventilation. Anesthetic management includes an awake or an inhalational induction, and when the endotracheal tube is placed, the bevel should be placed such that it faces anterior so that the posterior wall of the endotracheal tube occludes the fistula. If the patient already has a gastrostomy, then check for CO2 or air leak and reposition the tube as you see fit. It may not be possible to adequately position the endotracheal tube because of the position of the fistula to the carina. And in these patients, if ventilation continues through the fistula, then clamping the G tube intermittently to help ventilation may be necessary. In these children, you probably should have a gastrostomy tube placed ahead of time. There are multiple reasons as to why a child with TE fistula has intraoperative desaturations, and they include lung compression by surgeons, mediastinal retraction, tracheal deviation and compression, direct cardiac compression, and because of this, frequent manual ventilations are to be coordinated with the surgeon to help with oxygenation and ventilation of these children. Remember that surgical retraction compresses the great vessels, the trachea, the heart, and the vagus nerve. Any drop in blood pressure should initially be treated by removal of this surgical retraction or relaxation of these retractors. These patients usually require 100% FiO2 despite the risk of retinopathy of prematurity. Following surgery, most patients are extubated within a day or two. Preterm infants and those with respiratory problems may need prolonged ventilatory support. Complications of TE fistula include tracheomalacia, leak from the site of anastomosis, esophageal strictures, recurrent fistula, reflux, and dysphagia. Moving on to the next topic. Necrotizing enterocolitis. It is a life-threatening intestinal inflammation and injury state. Most common acute gastrointestinal illness in the neonatal period. It affects about 1 to 7% of neonatal ICU patients, and 80% of which occurs in preterm and low birth weight infants, especially those that weigh less than 1.5 kilos. The etiology is probably multifactorial. They have an immature intestinal mucosa. They predisposed to intestinal ischemia and reperfusion injury, could be secondary to infection and immature immune response. Risk factors for necrotizing enterocolitis. Top of the list is prematurity. Second is asphyxia, followed by hypotension, umbilical vessel catheterizations, UAC or a UAV, UAC or a UVC. Bacterial or viral pathogens, enteral feeds, especially aggressive advancement of enteral feeds, patent ductus arteriosus, use of indomethacin as this can decrease intestinal perfusion through inhibition of cyclooxygenase system, respiratory distress syndrome, in utero cocaine abuse, and congenital heart defects. They usually present with abdominal distension, tenderness, redness, or bluish discoloration of the abdominal wall. When feeding residues are checked, it's often present and could be bilious. They lose bowel sounds. There could be gross or occult blood in the stool, and non-specific signs like temperature instability, glucose instability, lethargy, apnea, bradycardia, and hypotension should suggest a possibility of necrotizing enterocolitis. Radiographic findings could be nonspecific bowel dilatation, thickening of the bowel wall, fixed dilated loops, pneumatosis intestinalis, portal venous gas, and free intraperitoneal gas. Lab findings include thrombocytopenia, leukocytosis, neutropenia, hyper or hypoglycemia, metabolic acidosis, and a left shift of white blood cells towards the immature precursors, and the presence of DIC. Children with necrotizing enterocolitis usually are not emergent surgical candidates. Medical management is the first line of treatment, which includes having the patient NPO, putting in an OG tube for gastric decompression, resuscitate using volume, initiate antibiotics, intubate the child if necessary. Blood and platelet transfusion could be necessary, and these children may need circulatory support with inotropes. The surgical management, if the children are less than 1 kilo, then percutaneous placement of intraperitoneal drains have shown to increase percutaneous placement of intraperitoneal drains have shown to decrease mortality and morbidity in these children. In children over 1 kilo, then resection of the diseased bowel, formation of stoma, or sometimes primary anastomosis is considered. The anesthetic management is to continue the resuscitation that was initiated in the neonatal ICU, usually an opioid-based anesthetic technique with muscle relaxants, and these children require postoperative ventilation. The survival after medical management only is about 80%. The survival of these children who need or have failed medical management and need surgery is around 65%. A few words on intestinal obstruction. The most common cause of intestinal obstruction could be intestinal malrotation in newborn babies. Malrotation of the intestines is a congenital anomaly that occurs secondary to a spontaneous abnormal rotation of the midgut around the mesentery. This has an incidence of about 1 in 500 births. It's pretty high. A majority of these patients present with symptoms of partial or complete bowel obstruction and could be acute or chronic in presentation. The most serious complication is a midgut volvulus, which can rapidly compromise intestinal blood flow and lead to necrosis and cell death very quickly. Hence, this is a true surgical emergency for an exploratory laparotomy and correction of this malrotation. A third of these cases can present during the neonatal period. The signs and symptoms of a child with intestinal obstruction include those with could be either partial or complete bowel obstruction. Treatment is very similar to treatment with children who have necrotizing enterocolitis, which includes maintaining the patient to be NPO, decompress the stomach, resuscitate these children well, initiate antibiotics, intubate if necessary, blood and platelet transfusion if necessary, provide circulatory support with inotropes, And of course, in these children, surgical treatment is the definitive treatment. A few words on meningomyelocele. This is the most common congenital neural tube defect. It results from incomplete closure of the neural tube, and the incidence is 0.5 to 1 per 1,000 live births. A meningocele is protrusion of the meninges only. A meningomyelocele is protrusion of neural elements and their coverings. The challenges for the anesthesiologist taking care of these children is positioning a child with the meningomyelocele. Because of this meningomyelocele, laying them supine could be hard or challenging. We may have to intubate these children in the lateral position. They also have a high incidence of coexisting Chiari malformation and development of hydrocephalus, which could require a VP shunt placement either on the day of meningomyelocele repair or a few days postoperatively. Patients with meningomyeloceles need to be corrected within 72 hours post-birth to prevent infection and ventriculitis. And that's the end. Thank you.